The next presenter is Tania Gibbie. Tania is a clinical and health psychologist and the TIC clinical panel lead for mental health. She's worked extensively with people experiencing addictions, chronic pain and relapsing depression, and has a keen interest in the psychology of both physical and mental health and illness, specifically relating to health behaviour change using motivational interviewing. Tania is also the trainer for the Mindfulness Training Institute Australia and New Zealand, as well as a network psychologist for the AFL. So Tania, you're about to present on psychological interventions for pain. So I'll hand it over to you.
Thanks very much. Thanks for the introduction and great presentation, Jack. That was really, actually it's a bit of a hard act to follow. I think my slides are nowhere near as exciting as Jack's. So I apologise if you get a bit sleepy this time of night with my dry PowerPoint slides, but let's go, see if I can keep you all awake. Let me just do that. So does that look okay, Adrian? You can see that all right?
Yep, that looks great. Thanks.
Fantastic. So, so what I'd like to do tonight is just to really cover some of the psychological aspects of pain management, and hopefully give you a few tips and a bit of a call to arms to ensure that you're utilising some psychological strategies when working with clients or patients with chronic pain or persisting pain. If you're not doing so already, I'm sure there's lots of great work being done out there already. Just I guess as a bit of a definition, and I'm sure a lot of you are really familiar with this already, but there's a really clear difference between acute pain and persistent pain. So by definition, pain is being described as an unpleasant sensory and emotional experience. So it's not just a sensory experience that we often kind of grow up believing that it's just this physical thing that happens in my body, but there's also an emotional experience that goes with it just purely by the definition. And it's influenced by attitudes, beliefs, personality, social factors, and can affect our emotional and mental well-being. So acute pain, as we'd all be really familiar with, it's considered to be short-term and it will often occur after, some sort of trauma or surgery or other condition or illness. And it's really kind of helps us to act on this warning system that we need to seek help or recover or rest. So it seems to have a really clear reason for being there when it's an acute pain. But it gets a little bit more complicated when it turns into a persistent pain condition. So it's when the pain is lasting beyond what we'd expect for usual healing. There's this sort of time frame of around 3 months, so that we expect most tissue and bone, what have you, to heal within that time, and that the pain for some reason persists beyond that. And it can occur because of following traumas, like as acute pain, but sometimes it can just occur for no clear reason. So, occasionally people will just wake up and pain has started and there seems to be no real reason. So sometimes the pain can be a symptom of other diseases, but often it can be a disease in its own right. So it's really becomes characterized by those changes within the central nervous system. Usually by the time I see clients with persisting pain, we're not months down the track, but it's years down the track. So it's really when it's become this entrenched and difficult problem for people that they get sent to a pain clinic and a pain psychologist. So unfortunately, we don't really get to see them in the early intervention phase, which would be ideal. But I guess the key aspect that I'd like us to keep in mind is that although clients can have the same or similar injury, their experience of living with pain can be vastly different. And that really speaks to all of the other components that we need to consider in chronic pain management. So someone can have exactly the same injury. One person has no pain, someone has absolutely debilitating pain. But pain is always real, regardless of what the scans say and what the tests are showing. And as Jack discussed, obviously and really gave some great descriptions about what we want to do. I love the dance floor and the mosh pit analogy. that really the best practice and widely accepted model is a biopsychosocial approach to chronic pain, and that we have to take this whole person approach, and that means multidisciplinary. So it's never psychology on its own, or physiotherapy on its own, or medicine on its own. It really needs to become this multidisciplinary approach. And that we need to look at, you can see in this lovely little picture here, that the physical symptoms are in the middle, but everything else needs to be considered: our mind and its systems, our body and its systems, our environment and its effect on us, and our effect on the environment. So the two main pillars for the treatment of chronic pain, really in terms of multidisciplinary beyond medical, which could be medications or injections, some sorts of interventions. The two main pillars are physical conditioning, which is to raise paced activity levels, and also psychological training, which is to improve pain coping strategies and life coping strategies, to increase self-efficacy. So self-efficacy is this confidence that you have in your ability to do something. So in terms of pain management, it's a really great indicator for people's ability to cope with their pain, so their self-efficacy for managing their pain. So it's really kind of like this innate belief that you can manage something and cope. So psychologists or psychological training hopefully will improve self-efficacy, improve distress management strategies as well. So this illustration by Michael Nicholas, who's a psychologist based in Sydney at the Royal North Shore. He's kind of one of the most well-respected psychologists in the area, certainly in Australia, and he developed this image of how chronic pain can become a problem. And when you see that all of the interactions that are going on here, you think you have pain as the starting point, perhaps, in this illustration, and it leads to, for example, reduced activity, unhelpful beliefs and thoughts, repeated treatment failures, so you're being sent off for different surgeries, interventions, scans, but none of them seem to solve the problem of the pain. Long-term use of medications or sedatives, and loss of jobs, financial difficulties, roles in life. You know, all of the fun stuff in life, all of your hobbies, all of those things are reduced, and it leads to physical deterioration, feelings of depression, helplessness, sleep problems, perhaps side effects from the medications, and how they all interact with each other. And I'd say now probably more so, there'd be more arrows that we know lead back to amplifying the pain. So opioid-induced hyperalgesia, so more pain because of using long-term opioids, perhaps even more pain because of not exercising and moving our body. And overall, this leads to this picture of excessive suffering. So we have pain, but we also have all of this suffering that goes with it. So I think what I'd like to really get across is this concept that chronic pain management is complex, it's complicated, and it needs to address the associated emotional distress and the behaviours that go with it, and not only the pain. And it becomes incredibly futile if we're purely seeking a pain reduction as our outcome. So for those of you out there in primary care, first of all, I take my hats off to you, but I really would like to encourage you to, with your patients or clients with chronic pain, to screen for psychological distress in those clients. So often coming to an appointment or an interaction and being able to talk about your pain is a much easier thing to do than actually talk about the emotional distress and the toll it's having on your life. So I'd really encourage you to start screening for psychological distress if you're not doing so. The K10 is a questionnaire that's commonly used out there in general practice. So I'd encourage you to use that with your clients or patients with persisting pain. I'd also, often we'll just consider the total score for the K10, you know, if you're doing a mental health plan or something like that. But I'd encourage you to actually look at the different item responses. So each question, you could look at it and kind of reflect back to the patient, you know, why did you give it this score? And it's a really great way to have a conversation starter and to kind of drill down a little bit more into their experience. So there's a few things that I think can be done in primary care. The other really important aspect is that you could introduce or be involved in introducing the biopsychosocial model of persistent pain, and explaining that the biomedical component is only really one small part of the treatment for persisting pain, and that we really have to consider the whole person, the mind, the body, their social connections, how involved they are with people they care about. All of those different parts of the person needs to be part of this whole person approach to pain management. Also, in some other things to consider doing in primary care, if it's not being done, or just to maybe have a bit more of a think about with your next patient with persisting pain, is to have that opportunity to provide some education on pain, but also on sleep hygiene. We know, as Jack mentioned as well, that sleep is absolutely fundamentally important for so many different parts of our well-being. Our mental health is really affected by poor sleep. I know how grumpy I feel myself after a bad night's sleep. So you think about sleep deprivation. So really being able to kind of put some effort into sleep hygiene and strategies for sleep is really good. But also some education on mental health and the interplay between persisting pain and our mental health. But in terms of pain education, I think if you can consider the role of the education is about trying to assist the client or the person in front of you to jump from this acute model of pain management to a chronic disease model of self-management. So we're trying to assist people to move from, we grow up with these ideas that, when we're in pain, we rest, we take medication, we wait for the pain to go away, and then we can get on with life. And applying that same strategy to chronic pain really is the thing that leads to so many difficulties. So if we can help our patients jump over from that acute model to a chronic model, and realizing this is a whole different ball game here, and we need to manage it in a different way as well. The other part of education is really helping to move the focus, or assisting the client to kind of shift their goal from being pain reduction to an active management role. And that's a really tricky thing for people to accept, this idea that we're not actually going to chase pain reduction as the outcome of our consults. It's actually about how do we improve your life despite the pain. And I get it. I would be chasing pain reduction for as long as I can as well. It's a really tricky thing for people to adjust to, but that's part of the role of good chronic pain management, is to help people move that focus. So a really important thing to do is to explore patient goals and their personal values. So when we talk about goals, it's really important that we find out what it is that the patient wants to change in their life, what they want to work on as their goal, or improve, do more of, or do less of, but what's important to them, rather more so than what we think is important to them or for them. So it's really about trying to find out what can they hang their hat on, or what is it that is important to them, that they value, that will help increase their buy-in to the idea of pain management. So is it that they want to be able to walk around the block and not be in bed for another, for the rest of the day once they've done it? Is it that they want to be able to just, it could be sit in a chair at a pub for longer. So it might not be the goals that we think are really important for their health, but what is important to the person in front of you. And also what their personal values are. So there may be things in their life that are at risk, or things that they value that are under some sort of threat because of the way they're managing their pain. It could be their relationships or their work. things that they really hold as strong personal values. So it's really great to explore patient goals and their values and trying to use perhaps motivational interviewing or something like that as a way to help increase their buy-in to focus on these goals. So helping move away from the goal of pain reduction as being the only thing we're focused on, to exploring their goals and improving their life in spite of the pain. I would encourage you to consider a referral to a psychologist for active and goal-focused intervention. So psychology in pain management is not long-term psychotherapy. It's really about active strategies for coping with chronic pain. And as Jack was saying, pain clinics aren't the last step in the road of pain management, but neither is psychology. So, you know, we really tend to be considered the last thing of, oh gosh, nothing's working, I'll send you to the psych. But really, it would be great if we could be involved a bit earlier in pain management. So always worth considering that as well. So in terms of what the psychologist would do, I'd just like to explain a little bit about what the psychologist will do. So in terms of pain management, the psychologist will be helping to try and improve coping strategies and increasing the self-efficacy of the client's pain management and to improve their distress management strategies. So we'll use psychoeducation, as I explained before, and motivational interviewing. So something that perhaps a lot of you might be familiar with already out there. So motivational interviewing is a communication style. So it's based from the counselling world, but really has been shown to be very helpful in helping people resolve their ambivalence to change. So it's really a useful strategy, can be used in really short consults. So, 5 to 10 minutes using motivational interviewing can be shown to really help improve people's motivation and adherence to different healthy behaviours. So the way it would be used typically in pain management would be to try and help perhaps people decrease their medication use if that's something that's needed, and also their reliance on passive strategies. So helping again to kind of shift them over to that more active and goal-focused way. So the main pillars of psychological treatment in pain management are CBT, cognitive behavioural therapy, acceptance and commitment therapy, so ACT. Mindfulness-based cognitive therapy is a group program that I am particularly fond of, something that I teach as well, and mindfulness-based stress reduction. But CBT, ACT and mindfulness-based cognitive therapy, which is an 8-week program, it really is looking at addressing the cognitive distortions that clients can often come with to psychology. So catastrophizing is a term that's widely used in pain management, but it's really about helping people to address these distortions that come with their responses to pain. I'd say it's really, really important to get an understanding of what the patient believes is the reason they have pain. So for many people, they would have been told by numerous health professionals out there over the years, and very well-meaning health professionals, that, oh, this is the worst scan I've ever seen, your back is terrible, or this, so really kind of catastrophic language that sticks to their mind. So it's not uncommon at all. So, if somebody has been told that their back is deteriorating, or that they've got the spine of an 80-year-old or something like that, and then every time they go to bend over to pick up the washing basket, they have an increase in their pain, this thought of, oh, my back, it's crumbling, or this is because I've got a slipped disc. So they have this vision that their disc is doing something strange or bulging. And so it's really, really important to kind of get an understanding of what that person believes is happening when they have an increase in their pain. And that's really can be incredibly powerful to help address that. So some specific pain strategies, pain management strategies that tried and tested are applied relaxation strategies. So I encourage you all to teach those if you have that opportunity. And it can be as simple as a 10-minute progressive muscle relaxation or a breathing practice. So these strategies that can actually be put in the place of unhelpful coping strategies when pain can increase. We teach a lot about pacing activities along with our physio colleagues. So we're trying to teach people how to pace out their activities over a day. It may take, you know, a couple more hours than something usually would, rather than this booming and busting pattern of activity. So typically patients will come and they'll try and get all of their jobs done in the morning, and then while they feel good, and then rest in the afternoon because their pain has gotten so much worse. So we're really trying to help sort of turn that on its head and just learn to break up activities, space them out over the day, so we can move away from this pattern of a lot of activity and then resting in response to pain. A lot of activity, rest in response to pain. And over time, people can really build up their endurance and their tolerance to more activities. Another pain-specific strategy is this thing we call desensitization, and it's really helping people approach the natural avoidance that they may experience to pain sensations in their body. So rather than trying to push it away or ignore it, actually turn our attention to the pain sensations and learn to relate to them in a slightly different way. Hopefully over time, what that does is help to uncouple the pain, the sensation in the body, and then the thinking and the feelings and the extra reactions that go on, help to kind of separate them all so they can be part of an experience, but something that doesn't necessarily have to overwhelm us in that moment. So other things that we focus on too are general life strategies, sleep hygiene, as I suggested, communication skills, how to, you know, effectively assert yourself when in pain and when not in pain, and problem solving skills, things like that as well. So just a little, an illustration of the CBT model of how these concepts interact in terms of pain management, and how we can try and intervene at these different levels. So the cognitive, so perhaps thinking that there's been maybe an external trigger or an internal trigger that then sets off this this cascade of experience. So it could be that you have an increase in your pain, or it might be that you hear something externally to yourself, a conversation with somebody. In this example, it would be an increase in someone's pain after doing something, and the thoughts are, oh, here we go again, I can't do this, I'm a failure. What if it's like this forever? And then the feelings that go with that, feeling sad and hopeless. And then in response to that, the behaviours are to lie down, take medication, avoid activities, avoid people. And that leads to feeling lethargic and having headache. So these are this sort of interaction, all feedback on itself. So feeling sad and hopeless, our thinking becomes more negative. We're more likely to avoid. That leads to, again, more thinking about how hopeless we are, and the cycle continues. Another common interaction that perhaps leads to more of an anxiety response would be, oh, what happens if my pain gets worse? My spine is so bad. And then it leads to heart racing, dizziness, more pain, feeling fear and stress. I think that's a 5-minute warning. Avoiding situations and activities. So, and then that, again, that cycle interacts with each other. So these are the different aspects that we would then try and unpick and start working on. So perhaps relaxation strategies to help with the physical heart racing and dizziness, and the feelings of fear, the cognitive strategies to address those cognitive distortions, trying to help find things that could be perhaps a little bit more rational response, and trying to intervene. Still perhaps rather than avoiding situations, trying to engage with things that that can help improve our mood in some way. So this is really kind of a basic model of how the cognitive therapies being ACT, even mindfulness and CBT, these are the different aspects we're trying to work on. And seeing how that these can be interrupted by these different things we put in place, like desensitization, relaxation, reframing the way we approach our pain and think about our pain. It's not about being Pollyanna and pretending everything's okay and just being positive, because that's not the case. It's not trying to put a positive spin on things, because that's not life, is it? That things are always positive. It's really just about trying to be rational and improving that negative self-talk. So I've got a whole lot of resources here that I think you'll get these slides to share with you, but there's some online resources. There's two here, This Way Up and also MindSpot, are both online programs for patients. MindSpot is free. This Way Up, I think, is like $59 or something like that. And they're both monitored programs. MindSpot has telephone counselling and coaching. So they have chronic pain courses. They also have other excellent courses, well-being, stress management, mood, OCD courses. So fantastic resource based out of Macquarie University. And MindSpot is, This Way Up has a fantastic array of programs as well. So all evidence-based, primarily CBT-based. You can work through them with your patients as well. So they could sign up and you could work through the modules with them, or they could report back to you as a way of doing that. There's also some fantastic pain courses through Macquarie University in a similar way. So really useful resources to, if you can't get your client or patients into a pain clinic or to see a specialist, something really great to get started with. Pain Australia has some fantastic fact sheets, reports, different languages, tools, different apps. So really worth having a look at as well on explaining pain. Also, this is a fantastic little clip called Brain Man. So it's a little cartoon clip just explaining about the role of the brain in pain management, and trying to, often if people hear that their brain is involved in pain management, they will misinterpret that like it's their imagination, but this is hopefully something that helps explain that too. So there's a few more things there. So thank you. I will stop there and stop. I'll just stop.
Thank you so much, Tania. Thank you very much for that. Very, very interesting. And